Okay, hello everyone. As over last 3 weeks, I have seen a lot of cases of headache. So I thought it would be appropriate to go into details of approach to headache. And I also got to know new treatments of migraine, which I
What is
didn't know
this?
of. So I'll also talk briefly about those treatments.
Is that an L or maybe
Looks like a T.
So,
It's not a T. It's a C. C
so
I
am I audible? I think someone is speaking. Uh,
Let me mute people. Hang on. We'll start again. Let's see if participants. Oh,
So today, let's talk about headaches. So headache is the most common symptom that we see in our clinics. So virtually everyone in their lives at some point has headache. So let's go deeply into the mechanism. Uh, so to feel the pain, there has to be some pain receptors. Uh, So let's find out where these pain receptors in the head are. So there are no pain receptors inside the brain, surprisingly, but there are pain receptors in the arteries of the brain and veins. It's in the meninges, extracranial vessels, scalp, neck, and facial muscles, and the sinuses, eyes, and teeth. So it's mainly mediated by fifth and ninth cranial nerve and upper cervical sensory roots. Uh, So among the headaches, the two most common headaches are migraine and tension headaches. Uh, in and the third one is the primary headache is cluster headache that we can commonly see, although it's not as common as migraine and tension headaches. And let's go deep into the mechanism of migraines. So whenever you see cases of migraines in your clinics, you will often get a positive family history. So there might be some history in their parents also, or in their grandparents, and it's polygenic in nature. When I was in medical school, for the first time I learned the mechanism of migraine. I was taught that uh, it is vasoconstriction of vessels in the head followed by vasodilation, which causes a headache. However, the idea has changed now. It's more of a neurogenic in nature. So it is described, its mechanism is described as spreading cortical depression, a wave of neuronal depolarization, which starts from the back of the head and go to the front. And and it causes the aura that precedes the migraine. And this wave of depolarization activates trigeminal pain neurons, uh, which releases some neurotransmitters, and this whole system is called trigeminal vascular system. So which causes the headaches. So some of these transmitters are CGRP, substance P, and 5-HT, serotonin. So which is the basis of some of the medications also which we use in the migraine. So these neurotransmitters cause painful meningeal inflammation and vasodilation. As you will see, patients of migraine, most of the patients will describe this pain as pulsatile in nature. Pulsatile, or you can call it throbbing. Previously, we used to think that it is due to the pulsatile nature of our vessels, pulsations in the vessels which are perceived. However, it's not due to that. It's due to increased sensitization of neurons in the brain, in our head, due to trigeminal vascular system. So this sensitization causes us to perceive CSF pulsations and head movements very easily due to increased sensitization. So which usually we do not perceive. However, in cases of migraine, these pulsations are perceived, which is the cause of throbbing headache. And the same sensitivity also makes us uncomfortable to light and sound. The mechanism of tension and cluster are not very much clear, so I didn't go much deeper into it. So before proceeding further into the other causes of headaches, let's dive deep into the two most common causes of headaches. The most common is tension headaches, and then there is migraine headache. Uh, Tension headache is usually bilateral and symmetrical, and patient says it's band-like sensation and tightness in the head, and it's usually of mild to moderate severity. And now this mild to, I'm saying mild to moderate, this is a very subjective thing to say, so I'll say that it doesn't uh, get into his daily life much. Patient is able to do his daily works and routines. And at the same time, migraine is tends to be unilateral. However, a bilateral headache doesn't rule out migraine, so never use this as an exclusion criteria. Many cases of migraine can be bilateral also, and it's usually of moderate to severe intensity. So severe in this case is that patient might not be able to do his work and his daily activities, and patient it might severely impair his function and his quality of life. And it and now comes to now coming to duration. Migraine might last up to, yeah, on an average it lasts around 1 hour, a single episode. However, it can be smaller than that, or longer, up to 3 years, 3 days also. So as I mentioned already, that it can be throbbing or pulsatile in nature. Coming to associated symptoms, tension headache doesn't have much associated symptoms. It's a benign headache kind of, so doesn't cause much disability. However, migraine can, on the other hand, can be quite disabling, and 30 to 75% of patients experience a prodrome, uh, which doesn't cause much despair to the patient, and it usually comes up to can come up to 48 hours before the onset of headache, and it can be perceived as irritability, food cravings, or yawning. And 25% patients get an aura. Patient can have light flashes, fortification spectra, scintillating scotomas, which I'll show you pictures how they look. And patients might have neuro findings, focal neurological findings like weaknesses or vertigo and numbness or tingling, etc. And it can last up to 1 hour before the headache onset. And along with that, aura might go away once the headache comes, or it may go into the headache also. And patient might have vomiting, photophobia, phonophobia, or allodynia associated with it. Phonophobia is like patient is averse to sound, and allodynia is a non-painful stimuli will be perceived as painful stimuli. So can you see these pictures? Fortification spectra. It looks like a jagged lines, zigzag lines, and and on the right side you can see scintillating scotomas. These are the visual phenomena that are commonly seen in migraine patients. Uh, on, but these are seen only in 25 cases percent of migraine. Most of the cases do not have this aura. So, according to the etiology, we classify migraines into two categories: primary headache syndromes and secondary headache syndromes. In primary headache syndrome, we don't we get nothing on imaging or uh, imaging or other studies. They are mostly benign kind of headaches, and uh, and they are mostly chronic and episodic. On the other hand, secondary can be sudden in onset and can be quite disabling sometimes. So the most common is tension headaches that I have already explained, and then migraine headache can be divided into with aura or without aura. The without aura migraine is a more common one. There's no aura, and 25% cases are with aura. So the most common is classical migraine. So in which we get typical aura. Typical means the visual symptom that that I explained are seen in the both eyes. Then there's another type, retinal migraine, in which case we'll get the visual symptoms in only one eye. And then there is hemiplegic migraine. The patient will have weakness of one side of the body, and which might resolve after which will resolve after the headache disappears. However, in some severe cases of migraine episodes, when there is persistent headache, it might evolve into a stroke sometimes, quite rarely, but it can happen. Then there is basilar type of migraine. It will cause symptoms of vertebrobasilar insufficiency. Patients will have migraine along with vertigo, dizziness, dysarthria kind of symptoms. Uh, there are some uncommon syndromes also in primary headache syndrome. Uh, Cluster headache is the first one. It comes under the category of trigeminal autonomic cephalgias, and there are three types of headaches we see under this category: cluster headache, paroxysmal hemicrania, and short-lasting unilateral neuralgiform headache, SUNCT. So these all three are very similar in nature. They're all unilateral. They all cause congestion in the nose and the eyes. They can all cause temporary or short lasting Horner syndrome on the one side, and swelling of the face on the one side. But the primary difference in all these is the duration. Cluster headache can last up to 3 hours, and paroxysmal hemicrania can last up to 10 to 15 minutes, and SUNCT can be as short as seconds to minutes. And the difference between cluster and migraine is that migraine is common in women, and cluster is more common in male patients. And as compared to migraine, the cluster headache patients will be restless, and patient will give a history of disturbed sleep at the night, will have difficulty sleeping at night. On the other hand, migraine patient is usually uh, uh, not restless. Patient is typical history of lying on the bed in her room all day. So that is the primary difference, and it's more common in women also, the migraine. Then there is primary thunderclap headache. Now the term thunderclap just means the acuity of the headache. It's the gap between onset and the peak severity is very short. So primary thunderclap headache will always give a suspicion of subarachnoid hemorrhage, but imaging and angiography will show nothing. And then there's trigeminal neuralgia. However, it's not most of the books don't consider it under headaches, and it's not a true headache. It's more of a it's a involves the trigeminal nerve, and it's kind of a lancinating pain on the one side of distribution of trigeminal nerve. It's not a true headache per se. Coming to secondary headaches, so it can present as an abrupt single episode as opposed to chronic nature. So some causes are very clear: hemorrhages, tumors, and brain abscess, meningitis, CVT, chronic venous cerebral venous thrombosis. Arterial dissections could be carotid dissection, or could be in the posterior circulation also. Then there is a term called reversible cerebral vasoconstriction syndrome. It's a rare entity, and patient will have gives recurrent episodes, gives history of recurrent episodes of thunderclap headaches, and the dynamic neuroimaging will show some dynamic changes. However, there will be no subarachnoid hemorrhage in this case. Then there is pseudotumor cerebri, which is now called idiopathic intracranial hypertension, which will cause early morning headaches. Like all raised ICD headaches cause are usually early morning after waking up. Then there is post lumbar puncture headache, which is a well-known side effect of a lumbar puncture. Post head trauma is also a cause of headache, even if there is no intracranial hemorrhage. Then there are strokes, ischemic strokes also, which can cause headaches. Then the other external, the pathology is external to CNS, like sinusitis, hypertension, hypertensive emergencies, acute accelerated hypertension or malignant hypertension. Any kind of high BP can cause it. Then there is glaucoma, acute narrow angle closure glaucoma, temporal arteritis, that is well known cause of headache in the temple, around the temporal and temple distribution. So and then obstructive sleep apnea, preeclampsia, eclampsia pregnancy syndromes, carbon monoxide poisonings, substance abuses, and medications, commonly nitrates, which are usually prescribed in the patient of MI or coronary artery disease. And as they're known to cause venodilation, so they can cause headaches. And then there is one term called analgesic overuse headaches, which can happen with any abortive medications of headache, but they are most common in opioid medications. This is a whole summary or chart of the etiologies I discussed. Let's go over a brief approach of the headache. Whenever a patient of headache comes to us, if it's a chronic or recurrent in nature and there are no red flags, then most of the time there is no imaging is required, and most of the diagnoses are clinched on history, on the basis of history. So if it doesn't fit into this category, then will have to check red flags like thunderclap, worst headache, recent head trauma, anticoagulation use history, decreased level of consciousness, or suspicion of meningitis. These are the red flags because they can point to a potential dangerous etiology. So the first step is always go for non-contrast CT head in these cases to rule out hemorrhage or a mass lesion. If it's if it confirms the diagnosis, then we have made our diagnosis. And if it is normal or non-diagnostic and we are still suspecting some pathology in the CSF like subarachnoid hemorrhage or meningitis, encephalitis, so we'll have to go ahead and perform lumbar puncture. So if we see xanthochromia, yellowish tinge in our CSF, or we see RBCs, then it will point to subarachnoid hemorrhage. Now RBCs can be very tricky in CSF because very commonly we end up doing a traumatic lumbar puncture. So in that case, it will be very difficult to differentiate from subarachnoid hemorrhage, or is it subarachnoid hemorrhage, or is it traumatic headache. So we have to do one thing we can do in that case is we can collect CSF in subsequent 4 tubes, and we'll check the number of RBCs per high power field in first and fourth tube. If the number of RBCs is almost same, then it's traumatic tap. Then it is if it is same, it is subarachnoid hemorrhage because hemorrhage is in the CSF. If it is traumatic tap, the first tube will have maximum RBCs, and fourth tube will have minimum number of RBCs. If there are a lot of WBCs and increased protein and low glucose and positive gram stains, it will be suspected of it will be more likely to be meningitis or encephalitis. If the lumbar puncture is normal, we can continue our observation, or we can go for an MRI or other imaging modality. The third pathway is if we get a sign of a focal neurological deficit, or CT is normal, or we get symptoms of raised ICT, early morning headache, or we are suspecting cerebral venous thrombosis, those kinds of things, then we go for brain MRI or with the magnetic resonance angiography or venography to rule out those etiologies. I think that sums up our pathways, and most of the etiologies of the headache can fit here. So after finishing the approach, it was a brief approach, and now we'll go focus on migraine therapies. I'm adding migraine to this presentation is because I got to learn new therapies of migraine during my rotation. So I wanted to go into the details of these, and I'll also like to share with all of you. As we all know that management of migraine has two aspects. One is abortive therapy, and the second one is preventive or prophylactic therapy. So most of the mild attacks of migraine can be managed with the non-steroidal and non-steroidals or acetaminophen. And if they are very severe and not responding to those medications, we can use triptans, or we can also use antiemetics if there is associated nausea or vomiting. In emergency settings, we also have subcutaneous sumatriptan or IV dihydroergotamine or IV antiemetics. Among steroids, dexamethasone is also one drug which can be used, although there is no difference from other drugs in terms of relief of or immediate abortive relief. However, there is a slight decrease in the risk of early headache recurrence. So, as we know that these triptans are vasoconstrictors, so we'll have to use them carefully and avoid in the cases of ischemic heart disease or stroke and angina, uh, like even vasospastic angina like Prinzmental anginas, and uncontrolled hypertension, pregnancy, and basilar migraine. These are the newer treatments which are not used very commonly in migraine, but I'll still mention them. Uh, the transcranial magnetic stimulation, it's used as second line management in the patients of migraine with aura who do not respond to first line abortive therapy. Then there are calcitonin gene related peptide, which is a this is a neurotransmitter which is a part of trigeminal system, which is involved in the mechanism of migraine. And these two drugs uh, can be used as abortive therapies, but they are not first line yet. And then there is lesmeditan, which is a serotonin 1F receptor agonist, which is also a new drug. So now coming to prophylaxis, I think I can sum up prophylaxis in one line that, or in one line that whenever a patient is having a, hampered quality of life or poor quality of life due to headache, prophylaxis is recommended. However, let's go into detail about these points. The first one is frequent or long-lasting migraine headaches, or the attacks that cause significant disability or or diminished quality of life, or there are contraindications to acute therapies, or their acute therapies fail in the management, and there is the headaches are so frequent then that there is a risk of overuse headache. So these are the, and one indication is also that if the patient has more than 3 or 4 episodes of migraine headaches per month, some books also recommend that. So principles of preventive therapy are that it's a slow acting drug. The drug will take time to act. So our principle is that we start at low dose and we increase the dose gradually so that the side effects are minimum. And then we should know that they take at least 4 weeks to act. So in between we have to use abortive therapies, and it helps us preventing uh, the overuse headache. This is a brief summary of prophylactic drugs. We have beta blockers. Most commonly we use propranolol, metoprolol. I would like to mention that my mother has hypertension, so I use metoprolol in her. So it helped her migraine and hypertension as well. So we can uh, do it like that also. We can combine two diseases and treat it with one medication, and it's recommended to do that. And then there is calcium channel blockers. Most commonly we use verapamil. Verapamil is also a good drug, prophylactic drug for cluster headaches. Then amitriptyline, it is also a common use drug used for prophylaxis, and it also works in tension headache prophylaxis, those who have chronic and non-resolving headaches. So amitriptyline, I think it's the only uh, prophylactic drug that works in tension headache also. Then we have venlafaxine SNRIs, uh, anticonvulsants valproate and topiramate. Topiramate recently has been quite successful in treating in prophylaxis, and it's quite common these days to use in prophylaxis. Uh, you can guess that this is picture of a picture depicting Botox injections for prophylaxis of migraine headaches. This is recommended whenever our other prophylaxis fail, or patients do not want to take regular prophylactic medications, because Botox injections are done every 3 months. So we inject these into our frontal hair, muscles, and in the back of neck and the occipital muscles. So total, on an average, there are total 30 injections we do at once, and uh, they work for 3 months. Then they have to be repeated, and sometimes it's patient's preference also, because they don't want to take medications regularly. Botulinum toxin, it's recommended when there are headache, there is episodes of headache for more than 15 days per month for at least 3 months. However, it also depends on the choice of patients. Then there is a drug called pizotyphon, which is not a very commonly used drug. It's a serotonin blocker. Then the other therapies which have been successful and are, however, are not common to use, are riboflavin and simvastatin with a vitamin D combination. This is Emgality, or we can call it galcanezumab. This is a new drug approved in 2018. I found about this drug in this rotation, and this these are given as injections, subcutaneous injections, and the first dose is given as a total of 240 mg, and after giving that single injection, we wait for 1 month, and then every month we give 120 mg subcutaneously. So this is a regimen for migraine. And but this drug, mechanism of this drug is, it's an inhibitor of calcitonin gene related peptide. It's a monoclonal antibody. So as we know that CGRP is a part of the mechanism of migraine headache, so that's why it's effective. This regimen is for cluster headache. Uh, this is the monthly dose. So at a time we give 300 mg. So this works for both cluster headache and migraine headache. Its Emgality is the brand name, and the drug is galcanezumab. It's a monoclonal antibody towards CGRP. It's the only CGRP antibody approved by FDA for both headaches. So that's it for the today's presentation. I try to keep it brief, because as Dr. Naka said that we have patients also. So my references are listed here. So thank you so much for giving me a chance to present here, and thank you so much.